Okay, I'll start with this one. It's a quickie, just an interesting presentation of this lesion. So the finding here is a well-circumscribed, rounded nodule that projects over the apical left hemithorax. We can see the inferior interface of the nodule with lung, which is smooth, but we don't see the superior interface. Certainly we don't have an interface with lung. And here is the responsible lesion. I'll just go straight to an MR. I can't remember which shows it well, but it is a presumed schwannoma that's arising from the T1, left T1 nerve root. There you can see that component that goes to the spinal cord. So a presumed schwannoma just protruding into the apical left hemithorax, like that. And that shows it pretty well there. The next one is just an interesting case of a lot of air in the chest. So I'll show you this image. And starting up here, you'll already recognize there's a lot of air within the veins coming into the chest and a lot of air going into the SVC and the right pulmonary artery. And I know Travis will like this sign here. I'll just make this one up because we've shown that before. The appearance of air in a pulmonary artery. So here's contrast medium, here's the air, here's the bronchus, there's air there. So the context here apparently was a person that was in rehab and was found to be suddenly very hypotensive. And they tried to establish a separate IV in one arm. That didn't work. And they described using a pressure bag and infusing a bunch of fluid as they rushed her to CT. And these are images obtained in the CT. They did non-contrast and contrast, and of course the air is present before the administration of the contrast medium. So we surmise that somehow in the administration of the fluids and in all the rush to the CT scan and using a pressure bag somewhere there, the air got into the venous system. But nothing otherwise happened. She has the big pericardial effusion. That was a thing that was drained very quickly thereafter. And I think ultimately it may have been blamed on anticoagulation, but I'm not entirely sure. But that's a lot of air. In the heart. And then this one is an interesting case. So I'll show you this one in reverse order. This is the time when there's abnormality, but you'll see in a moment that this represents substantial resolution of pulmonary abnormality from a few days before. So that's the 15th. Here is the 12th. We disconnect these two. So again, here is the 15th. And on the 12th here, there was a lot more abnormality. So multilobar, multifocal consolidative opacities. There is a crazy paving pattern in the anterior and in the upper lobes, but otherwise a lot of consolidation. One can see down here that there are septal lines in the right middle lobe. So those septa are waterlogged, or presumably waterlogged. So the question is, what is this? And what is interesting about this patient was that about almost exactly a year earlier, this person had a similar event. So this is January of 2019. And here is the CT from January of 2019. And let me just disconnect these, that's really weird. So very similar, diffuse, in this case, ground glass attenuating opacities through the lungs. And initially in January of 2019, because he had a parrot, they suggested that this may be a really bad form of hypersensitivity pneumonitis, which I think is reasonable. But certainly on the current one, it looks a lot more than one would see with hypersensitivity pneumonitis, and certainly consistent with a form of limited acute lung injury. So they began to ask him a lot more about what he was doing at those two times. What was he doing in proximity to this and on this particular occasion? And ultimately they decided that, based on what he told them, was that this is related to this. So on one occasion here, and he provided a picture, he was drilling holes into the plastic here. He works at a mine, and you can see kind of the burn marks here of the heat in relation to these holes, and he was welding by doing something with these holes. And on the previous one, he was working or sawing plastic again. So they thought on both occasions he was vaporizing by virtue of heat some of the plastic. And there is the notion of isocyanate and as well as plastic and different ways of doing this. Let me show you this here. They basically attributed this to an isocyanate associated acute lung injury. These materials are used in a wide variety of things. And if you vaporize some of these things, you can get isocyanates. So you can get so-called occupational asthma from isocyanate, hypersensitivity pneumonitis, but one can also find case reports of lung edema attributed to isocyanates when you vaporize plastics, particularly polyurethane. So whether it's true or not, they blamed these two occurrences by a temporal relationship to working and heating and vaporizing the plastic on both occasions. So they basically told him to keep the parrot, but avoid vaporizing the plastic and working with plastic with heat like that. So wow. It seems pretty plausible to me.
In both of those, it was upper lobe predominant, correct?
Let's have a look.
If you do show can you show the coronal in the most recent injury?
Yep. So let me see. Let me show you the time when he was pretty ill, which is the recent one. So this is
diffuse, but definitely a lot of upper lobe stuff. Okay.
Yeah.
There, yeah.
So Howard, that yellow material is the plastic?
Yeah, that is the plastic. Now, I don't know if there's a coating of polyurethane on the surface of the plastic in addition. I don't really know. But they figured that because there was a lot of heat generated, either the plastic or the polyurethane on top of the plastic may have been vaporized. That's so the idea.
He was heating it. He was welding this stuff, or what was he? I'm wondering.
So on one occasion, he was drilling and or welding these holes, but it's more than just drilling. I can't remember exactly, but they said these are burn marks. He said these are burn marks, so it must have been a lot of heat generated around these holes. And on the other occasion, I think he was welding in the holes or in relation to the plastic in some fashion.
I'm surprised that you would weld plastic because it seems to me it would ignite. So I just wonder if that's really a plastic coated steel or metal or something like that. They look like Is that what you were thinking?
Yeah, because they described him on one occasion as welding. So maybe it's a plastic coated metal. I can't quite tell. But yeah, I can. It certainly seems quite thick. The yellow stuff, that is. And they gave me this picture. So it seems plausible that in some fashion he was vaporizing something, some plastic, and got some isocyanates. Mm-hmm. But that's what we did too.
Can you show the coronal on the first one real quick? Sorry.
The first one from the previous occasion?
Yeah, it's kind of it's a very neat case. Yeah.
Yeah, this one is January of 2019, so there we go.
Yeah, I mean, it looks like, it's funny, it does really look like an HP picture, huh? Interesting.
Yeah, and this healed, as I showed you, this healed pretty quickly. In a couple of days, it cleared substantially.
Did they treat him with steroids?
4 days. I think they may have started him steroids, but I don't know exactly when they did in relation to his admission. This was between the 12th, this one, and 16th, 15th, 3 days.
Impressive, yeah.
Yeah. Oh, I forgot to mention, they did a BAL, and he had neutrophils. He didn't have a high lymphocyte count. But then they started putting things together and eventually diagnosed him, presumably with that, with the isocyanate, presumed isocyanate injury. Okay, Jeff, those are mine.
Okay, let's see here. Peter, do you want to go next?
Sure, I can go.
All right, let's see. There we go.
Start off by showing this one. I actually saw this one, started dictating it about a half hour ago.
I don't see. There we go.
Okay. So this is kind of a complex case. I think we have a theory of what's going on, but see, maybe you guys have something to add. So this is a middle-aged lady. She has HIV, and she's getting scanned for dialysis access by her surgeon. So one thing is, there's a few things going on here, but she has this cavity in her right upper lobe, and it looks like it's thick-walled. So the first thing somebody with HIV, I was worried about TB. And you look carefully around here, it's not really the parenchyma around it. It's not really tree and bud, but it's more pulmonary. It's more like a venous congestion type of pattern. If you look at a bronchial wall thickening, and then so she has, seems like venous congestion around that cavity in the right upper lobe. Now the other thing is, if you look at the rest of the mediastinum, there's all these collaterals everywhere. So her SVC is occluded right there. But it doesn't really explain why the lung is congested in the right upper lobe. And the other thing is she doesn't have, so her right superior pulmonary vein isn't really visible. So she happens to have, and if you check here, she happens to have anomalous pulmonary venous return, or partial anomalous. You can see it here, draining into the superior vena cava, which is at this point obstructed. So she's having all this due to her partial anomalous pulmonary venous return and obstructed superior vena cava. The venous return from that upper lobe is obstructed, so she's having all this venous congestion. Now the thing that wasn't completely clear to me is how you see this bright contrast here in the right pulmonary artery also. So I'm not sure if that was from slow flow, because she probably has really high pressures into the right pulmonary arterial system. So she might have really slow flow, and that's why there's buildup of this, looks like a jet, or is it some kind of fistulization?
Is that on top of the pulmonary artery, or is it?
I think it's within the pulmonary artery, because there's slices below and above it. So
Okay.
This is still pulmonary artery.
So Peter, how much blood is going from systemic collateral straight into pulmonary veins? Because it looks like you've got quite a bit there on the left. So I think you're also developing just systemic to pulmonary artery collaterals.
Systemic to pulmonary vein.
Systemic to pulmonary venous collaterals, right?
Yeah, well, right, but I'm trying to figure out how it's also getting into the pulmonary artery, because it's definitely, you've got a lot of the spontaneous systemic vein to pulmonary vein collaterals from the SVC syndrome, but maybe there's also,
Yeah.
or they're bronchioles, I don't know.
Yeah,
clicking
there's actually a
between
delay also. I can show that to you guys. So this is a delay. They happen to be a delayed scan, so you don't see that anymore. I mean,
You know what else is interesting in the upper lobe on that lung window? See the little subpleural subtle things? I bet those are transpleural collateral.
Is that a different
Right.
phase that you just switched to?
yeah, they image for some reason. They image the more delayed phase. Yeah, so this is a delayed.
Yeah, you may
Go
have,
back to the arterial phase because that'll show those collaterals better because there's a differential in the pulmonary venous flow. And is the IVC patent?
The IVC. So it looks. Let me check on the delayed actually.
Well, no, look on the arterial because you're getting a ton of
Yeah, it looks
a
patent.
ton of right to left shunt.
Look, the IVC looks.
Because you can see on that arterial, yeah, on the arterial phase, this is a big right to left shunt because most of that blood is going into the left, I think into the left atrium via those pulmonary venous collaterals. You're essentially bypassing a lot of the blood through the right heart.
Yeah, I mean, yeah. I think in the normal before this superior vena cava obstruction, her return was to the right heart because she had partial anomalous venous return, right?
Yeah, and I agree. I think that this is a unique case of.
So I think it's trying to go into here, but then it's occluded. Yeah, so you're right. Yeah.
So that's causing an increased pressure back up in the right upper lobe.
Yep.
and yeah, I wonder if you do have communications from some of those vessels directly into that right pulmonary artery.
Yeah, I had never. I did a quick. So is that something you guys have seen? Because I wasn't sure if that's possible. I didn't know.
I've seen
I saw-
bronchial arteries directly communicate. I don't know if I've seen systemic veins directly communicate.
Yeah, that's true.
Huh.
I know when I was looking for some of our smoke cases, I found cases both Howard and I had shown with both SVC and IVC occlusion, where you just get tons of these right to left collaterals dumping straight into the pulmonary veins.
So, so tell me what you guys think is going on here. I need a summary statement that's nice and simple. So I'm seeing all these venous collaterals along the left side of the mediastinum and everywhere. Where do you think those are going? You think those are going to left atrium? Did you guys say? Or
I think basically they're just trying to get back to the superior vena cava is obstructed, so they're probably just trying to get back through the azygous system. They're trying
But
to.
they're not. They're going through the pulmonary veins. If you window it, you can see that a lot of those are going straight into pulmonary veins, especially on the left side.
Especially on the left side.
A window it just like a CTA window, and you'll see when you look at the left superior pulmonary vein and see all of that dense contrast going straight into the left atrium. So all of those left mediastinal collaterals are going right there into that left pulmonary vein, and same thing into the right inferior pulmonary vein. You can see how much denser they are.
okay,
Okay.
Yeah. the left atrium's nice
Right
and
there.
dense. That's impressive.
So is that an easier way than trying to go through the azygous to the IVC back into the?
Well, I don't know if it's easy. I mean, it's just a common thing that we see.
Okay.
I remember you showed a case where this happened in like a patient with lymphoma that had new onset of SVC syndrome, and these collaterals opened up. But it can happen like in these cases with chronic access problems like dialysis patients, and this is.
I see. Okay.
Just one more
Yeah.
thing before you go on. Can you show the coronal if you have it? Do you have one with the because are those tangle of vessels really going into the right pulmonary artery, or are they going on top of the right pulmonary artery and we're being fooled?
That's a good question.
This bronchioles for sure. I think that I'm not yet convinced it's going into the pulmonary artery.
Yeah, I wonder if it's just collaterals surrounding the pulmonary artery.
Yeah, I
Because
think so.
You can follow it even further out in the right lung, and even right there, that look of the left pulmonary artery, there's just stuff wrapping around it.
Yeah.
Yeah, that makes a bit more sense, I think. Yeah.
Yeah.
The
Okay,
interesting,
that makes sense. That makes sense. Thanks, guys.
but I think one of the things that's cool here is that the IVC is not picking up the collateral. It's not part of the collateral pathway here to any great degree. It's fairly
A
small.
little bit. Yeah.
And instead, I think the main collateral pathway seems to be that shunt to the left atrium.
To the left atrium. Okay. Yep.
So if this patient's hypoxemic, that's the reason why they have a big shunt. And if you want to evaluate for pulmonary embolism, you either have to do a delay phase or you have to inject via the IVC in this case.
Mm-hmm.
If you really want to opacify the pulmonary arteries.
Yeah.
Very cool case.
All right.
Very interesting.
Yeah.
Yeah, that's really cool because the bonus of the right partial anomalous pulmonary venous return, I agree with,
Yeah,
with
that
your description.
that
Yeah.
that added another layer of complexity.
The cause of lobar, right upper lobe.
And then the cavity, is that just something incidental? I still said it possibly could be tuberculosis in an HIV patient.
Something else.
Or MAC or fungus.
Yeah, or MAC or yeah, right. Yep. Okay. So this radiograph, there are 3 pacemaker leads, and then 2 of them are in their expected locations, projecting over the right atrial appendage and right ventricle. And then there's this one right here in the middle. And so what I'm showing is it's not a displaced pacemaker lead. That's where it's intended to be. This is something called his bundle pacing, which is a new alternative method that's being implemented now for pacing it's an alternative to the traditional right ventricular pacing, where the pacing's through the apex of the right ventricle. Essentially what this is they're inserting a pacemaker lead directly onto the bundle of his here, the interventricular septum, and then that provides a more physiologic synchronous depolarization of the ventricles. So the whole purpose of this is it's intended to avoid a lot of the adverse outcomes that they see with long-term pacing of the through the right ventricle. And I can show, so here's a few papers. This is where I just happened to run across these papers that they've been publishing recently about his bundle pacing. And then so I just wondered if we would see it on our x-rays, and I finally found an x-ray with one of these.
Yeah, nice example.
I've seen a couple of these things and it did confuse me. I thought, I said that one electrode is more medial than expected, and right, and it wasn't posterior enough to be in the coronary sinus, great cardiac vein.
Yeah. So I've actually when I first saw this, I asked some of my cardiology colleagues, and some of them hadn't even heard about it, and some of them had just knew very little about it. They asked the electrophysiologists, and they said that we'd started doing it at our institution. But they're technically a lot more challenging, just because finding the exact first of all, there's variant anatomy with the His bundle, and then it's a much smaller window to place that lead there.
Right.
So they're not commonly done yet, but they're potentially they could start doing them more and more.
Yeah.
The other advantage that's claimed in these articles that it would avoid, it could potentially avoid going through the through the tricuspid valve and reduce the tricuspid regurgitation. This is a young patient who came in with fever, cough, productive cough. And so the first thing I think about is multifocal pneumonia, somebody with fever and productive cough. This is chest CT. He's also immuno suppressed. This is chest CT. But it ended up not being, that's not pneumonia. He happens to have a kidney transplant a few years ago. And he also has this finding in his cheek. So both of these, so the lung consolidations and this lesion in the cheek, both were biopsied and came back as PTLD.
Wow, great.
And he was put on treatment, which essentially was just decreasing his immunosuppression. And this was 2 weeks later. What does PET CT look like? So significantly improved in just 2 weeks.
Wow, that's a lot of lung disease.
Yeah, yeah.
Wow.
Yep. And one last quick one. This is a patient. This is a patient with the known murmur since childhood. Lady. So known heart murmur since childhood. She's a middle-aged patient. So this was presumed rheumatic heart disease based on the history that they had. That's what the scan was ordered for, and I think that's what this is. It's essentially a valvular involvement of rheumatic heart disease. The interesting finding here is this shortening of the chordae tendineae muscles. So you can see how short the actual cord is, and then the actual papillary muscles pull the way up, all the way up here. Significantly restricted posterior leaflet, and then of course the regurgitant jet. You can see the tethering here of the posterior leaflet and the shortened.
Who's for the 3-chamber?
I don't have a good 3-chamber, so this is just a 4-chamber stack. But then also the aortic valve is involved with regurgitation and stenosis. Let me see. Maybe I see this one. Yeah, I think I didn't include the 3-chamber just for having too many images.
You show the short axis at the base.
Yeah. I'll show the short axis.
At the base.
I only have 2 short axis slices, but you can see the posterior leaflet is severely restricted. Anterior leaflet's still mobile to
Quite
some
thick
degree.
and low, and nodular. Yeah, not normal.
Yeah. So just kind of an example of rheumatic heart disease.
Wow.
And that's all I have.
All right, thanks. Great case.
Thanks, Peter.
Thank you.
All right, Seth or David?
I've
I
got
can go real quick.
a couple quickies.
All right.
So this woman has an abnormal inferior vena cava, and the abnormality extends into the right atrium. So it looks like tumor thrombus or something like that. So we can track it down into the abdomen. It keeps going and going. Some distended vessels elsewhere, and then we get down into this mass down here in the pelvis. And then she's had hysterectomy. So there was a complicated procedure involving chest and abdominal surgery, and they removed all of this stuff that was filling up the cava, and she's doing pretty well. She doesn't take a very deep breath, but she's doing okay. So let's see if we can show this in coronography here for maximum impact. Definitely not normal, and extending down to this mass here in the pelvis. Okay, so this was benign metastasizing leiomyoma, all the result of her previous uterine surgery, her hysterectomy years before. So this was benign smooth muscle tissue or muscle tissue. Leiomyoma shouldn't be smooth muscle. Okay, so first one of those I've seen. The stuff in
access to the veins and then just grew up the vein.
It's just the veins, right?
Like
So
slow growth of
slow growth,
so-called benign lesion.
right?
Isn't it the case that it's really probably just a low-grade sarcoma, right?
Yeah, and they called, as a matter of fact, they said that there was a little bit of atypia here, so they preferred to call it, low grade, but low grade tumor, and it's not quite as benign as a lot of the uterine fibroid tissue would be.
So how do they know it wasn't a primary caval low-grade leiomyosarcoma, which is the most common caval tumor? I mean, how do they know? How can they differentiate that from a leiomyoma? Did they see uterine staining on it? I mean,
they resected that pelvic mass too, and it was all the same stuff that was in the adnexa and stuff like that. It was all the same tumor all the way down to this pelvic mass. So the pelvic mass was leiomyoma. So I don't think it was primarily cava. Okay. I think it got into the cava via a gonadal vein and stuff like that. Okay, and then this person has a mass in the left lung base and has a CT scan that will confirm some abnormalities. Has a nodule here on the right and has nodules and including this bizarre cavity here with stuff in it. And this has been pretty much unchanged for several years. Okay, and they biopsied this lesion, and this is benign metastasizing leiomyoma. This woman had some uterine surgery. She'd had some scrapings and things like that, polyps removed and things like that. So she's had some uterine surgery. She did not have hysterectomy, and she didn't. They didn't comment on. She didn't have surgery for fibroids or anything like that, but she did have uterine surgery. So what it takes to get benign metastasizing leiomyoma is for a surgeon to jostle the uterus. So if you've got these smooth muscle tumors there, and you get some of them into the bloodstream by doing an operation, that's the situation in which some of these benign tumor cells can get to other locations and then start growing in those locations, basically forming fibroids in the lung in this case, and in the cava in that previous case. So our second case of benign leiomyoma that came up in the last week, so we ought to operate a clinic here for this condition. So live and learn. I think I'd seen maybe 2 other cases in the entire decades long career, and now I've got 2 in 1 week. So,
and on the mediastinal window, David, cavitation or low attenuation, is that, oh no, that's fat, never mind, but cavitation
it's cavitation, and then we get down into abdominal fat here. I think it's adherent to the diaphragm, but this was a cavitary nodule, and then it slowly evolved over several years. I think I've got imaging that goes back maybe 5 years in this case, and I don't remember when the cavity first appeared there. Okay, so those are my 2 cases of a rare diagnosis.
All right.
Gee, that's yeah.
All right, Seth.
okay, very quickly. So this is a guy who came in with back pain. There's a chest x-ray showing this, but CT nicely shows this very nasty lesion centered on one of these vertebral bodies, complete collapse, nasty paraspinous epidural gunk. Not a drug user, really he has a history of latent TB supposedly that was treated. Again, you can see it's kind of nasty. We're all thinking it would just be TB, but this was the path here, and this was all cocci. So this was a cocci infection of the spine. This is his only cited disease. So not everything is TB.
Welcome to California.
Yeah, no,
Yeah. So
Travis, you showed a
Cocci imitates TB, and one of our infectious disease persons says that granulomatous infections can look alike, and I think that generalization applies very nicely to Cocci and TB.
Yeah, because we said, someone showed it to me, it's like, oh, it's TB, and then nope, Cocci. So,
and when you look carefully at the lungs on a lung window, on CT, you don't see any Cocci lesions there that might have been the source for this.
This was red, but someone showed it to me very briefly. Yeah, little cluster of nodules there.
A little tree and bud down there.
Little tree and bud down there. But that's about it. So not sure if the tree and bud is related, maybe, may not be. But that's just Cocci spine. I don't remember this case was, this case has a lot of cool, where is my, okay. So this is nothing here that was bad. So BPA. So this is, we have a big CTEPH center here, people know, and we do a lot of this balloon angioplasty, and it's always really hard to see what the hell they're treating on these because they're not going for your most conspicuous lesions. They're not going for occlusions. In fact, they avoid occlusions on BPA. What they try to get are these, you see these linear white lines. Those are webs. And so that's what they're trying to hit. So you can see all these little webs in between the vessels. And there's a big web here, and they try to treat it. So here they put their balloon in, and I'm still not sure. They just moving this back and forth. It's kind of inflated. They're just kind of poking at it. And the angio post is quite good in terms of what, sorry. Let me go. Let me just see. Okay, so this is I didn't include it. Anyways, that all opened up, but then she started having some issues where she started coughing like crazy. So all that whole area that had was all kind of had a big web on it actually opened up. But then what you see is when she started having massive hemoptysis on the table, and you can see there's that badness there that shouldn't belong. And the patient then underwent some CTs, and let me just make sure which one is which. So I think this was the initial study, and she has a small amount of blood in her chest. So they got as you can see, this is just a massive amount of blood filling the right hemithorax, pushing everything down. They transfused her quite a bit. Her chest tube was pouring out blood. For some reason, I still have to look at her notes. They didn't take her back to the OR. They did an angio afterwards when they took her back, and there was nothing. You can see everything is displaced over. This is her esophagogastric tube, and there was nothing filling. So they thought it was tamponading, but she kept bleeding and pouring out. And then a few days later, had this study, and I'll just show the delay where you can see that. Well, this is the arterial phase, but here you can see this little guy, which is the blush I showed you before, just still pouring out blood. And this woman, and here it is, you can see this huge hematoma actually just spurting blood. And she went to IR, and they embolized this. very nicely and did quite well afterwards. But this is a case of, we do a fair amount of BPAs, and they have a lot of complications. Well, they do well. I mean, recent new studies coming out showing prospective double-blind studies showing they're better than medical management alone for distal disease, but they do have some complications, even though our center does a lot. So that was just a massive BPA-related hemorrhage. And then lastly, this is just a nice example. We get a lot of cases sent in, and it's not always 100% clear. We have cases where the vessels are abnormal, patients have bad pulmonary hypertension. They're called CTEPH on the outside. Personally, I don't love direct catheter angiographies. She clearly has, her upper lobes are completely obstructed bilaterally, nothing up here, labeled as CTEPH, which I understand. But if you look at the vessels, very weird and tortuous. But a lot of them do go away, but a lot of times after they go away, they come back. And the kicker here, let me just show this. The kicker here is, if I can pull this, which case is this? So here is her cath. And the cath has these very tortuous enlarged arteries. There's areas of narrowing. Here's the other side, focal areas of narrowing. And we said this is not CTEPH. And the kicker is if you look at the lima is gone. If you look at the left subclavian artery, got a severe circumferential narrowing, and basically it's gone. And then they did an MRA, and you can see there's distal stenosis. So this is basically a vasculitis mimicking CTEPH. And this is the one that we get confused on the most, or this case is pretty clear, but we have a lot of other cases that, you swear they look pretty darn normal or look like classic CTEPH, and then the surgeon comes back and says, no, that was vasculitis. Like this was a case here where this patient had a bunch of stenoses but clot everywhere. And you can see his focal narrowing gets bigger, another focal narrowing, and this was all CTEPH. I mean, this was all vasculitis. So,
Beth, do those patients have a lot of mosaic perfusion on the CT?
They do.
Nice.
So this is a case, like you look at this vessel, it's like, oh, there's a big clot here. Big thing, goes away, huge amount of clot, goes away, comes back, gets bigger, gets smaller again, comes back. And what I've learned from making a mistake a couple times is that when you see this really undulation, bigger and then smaller and bigger and smaller, even if there's some clot associated with it, you got to really raise your red flags that this is a vasculitis case. Now, this other case I showed was a slam dunk because there was clearly extra pulmonary disease, but they both have, imaging findings, or at least the mosaicism that would be suggestive of a CTEPH pattern. So, but nice vasculitis cases. And whatever, I don't know. I don't like the name vasculitises because we all call them Takayasu's or whatever, but Behçet's, giant cells, but some medium, large vessel vasculitis.
So could this be congenital rubella or something like that with branch pulmonic stenosis, that the first case that you showed, or would you invoke an inflammatory vasculitis rather than something?
Well, the first case, given that there's lima is out, this subclavian artery was severely stenotic and out, and she had severe infrarenal stenoses. This would be a vasculitis.
Got it.
This other patient is a young, that I just quickly showed, young patient, very young, and yeah, no, our surgeon knows right away. It's actually amazing. He comes back, he's like, that was not CTEPH, and he kind of gets, he's like, there's no vessel, because normally CTEPH, you clean it out, you do the intimal resection, the vessel just pops right open. And he says with these cases, when he does that, it's just nothing there. It doesn't pop open. You try to treat it and the vessel just ends. He says on surgery, it's dramatically different look. And we actually had a patient who died, unfortunately, when we called it something, we weren't sure. We thought it was CTEPH. It looked classic, and it was a vasculitis, and the patient died afterwards. So not always easy. Those are.
Okay, thanks. All right, so I was sent some cases from a pulmonologist in Greece, a gentleman by the name of Vasilios Tsilas, and he asked me to share them with you. And they're actually great cases because they have path correlation. And he also provided me some questions. So they all have diagnoses, but I'm curious, and what the discussions will be. So I don't have a lot of history on this one, but this one you can see has these little umbilicated nodules throughout all the lungs, and I think we've all seen cases of this. And so these are meningothelial-like nodules. And the question he asked is, how comfortable are people just calling it based on the CT appearance versus getting a biopsy? We've called this, I know in our practice, we've called this several times. Usually when there's stability, it's helpful, but I found if you can find some that are sort of have that umbilicated look to them, sort of like that one there and that one. I'll bring up the case report. Let's see. Yeah, I got two. So here we go. So here's the biopsy, and you can see the nodule here. And so, and this is interesting. He thinks you see that Cheerio sign or that umbilication because they form around the small airway encapsulating it. And so you're seeing the bronchial outline. It's not shown in this biopsy. And then this is what his question is do you find the CT findings characteristic enough to obviate the need for biopsy? And generally in patients where, they're not growing, they don't have a known malignancy, we have tended just not to biopsy them. What have you guys done in your practice?
Well, unfortunately, I don't know what your guys' experience is, but the vast majority of times I see these in patients with malignancies. I don't know what it is. I don't know if it's we're doing so many cancer patients in general.
Right.
But nonetheless, when it has that appearance and it's stable, I just say the vast majority, these likely represent minute meningothelial-like nodules and not related to malignancy, and just do your standard follow. That's what
especially women. I think they tend to be more common in females.
But have you seen them in a higher percentage in your malignancy cases, or no? Is that just me?
I think, like you said, it's just that half of all the
scanning
doing it are patients
selection bias.
Yeah.
Yeah, the good news is if you have enough old studies, you can usually find them because they don't seem to change. And interesting, talking to a pathologist years ago, he was saying they see them all the time and they don't even comment on them half the time.
Yeah, our pathologist said he sees them in a majority of all lung biopsies they do in adults.
Yeah, I'm comfortable courting them when they have that distinctive appearance. I don't even give a difference.
The other question is, when would you be uncomfortable calling them then? I think patients that have a pancreatic or GI adenocarcinoma, you'd at least want follow-up. Like I think on the first time, you wouldn't slam dunk them. But if you have stability.
Yeah, it's funny. Every case I've seen so far, I have priors and for many years. I don't know why that is, but.
Well, we've had PACs for 2 decades now, so it's a lot easier to get hold of stuff.
Yep.
Okay. Yeah, that's what yeah, that's what typically has been our approach here. Once you've seen a couple cases of it, you start to recognize them, and the stability is helpful. Sometimes, they're so small to needle biopsy, even if you bring them back in 3 months, they don't change. So this is a case, and I think I figured out the answer to it, but I'll show it to you. So this was a 90-year-old who presented with dyspnea, large effusion, and it was determined to be a chylothorax after they sampled the fluid. But that on the CT, they noticed some cystic lung disease, and then the question is this LAM or in a TS patient? Of course, he's 90, and so they didn't see any findings or any family history. But he asked about some stuff in the heart. But I'm going to show you. I'll show you the images and what I think is going on. It's a little bit different. Look at the So he's got looks like probably old TB or something in the upper lobes. And then there's the effusion. But if we look carefully, let's see, I think we have some thin cuts. Yeah. So these cysts, a lot of them are perivascular. They're sort of, not a lot of them, they're lower lobe predominant. To me, I think they're a good look for LIP, if anything, or going to give them a name. I mean, as far as the myocardium went, I was not as impressed with the fat. I think that's just the interatrial septum there. And then really, I think you're just catching normal myocardium there. So I don't think there's anything of TS. There's nothing in the upper abdomen. What caught my attention was this stuff here.
Ooh.
around the spine. And I think this is lymphoma obstructing the thoracic duct.
Yep.
So, but I wonder if he's got LIP, and maybe that's why he has, or he's got maybe a subclinical Sjogren's or something, and that's why he has a lymphoma. But this, I mean, these sort of look like this. Some of these at least look like the cysts that Howard's shown. We've all talked about sort of that perivascular basal predominant. It's not a huge number of them, but it makes you kind of wonder. And I think he's had it on top of it, and then he's got these little nodules all along his pleural surface.
I would associate the cyst causally with the lymphoma. It's all of a piece.
Yeah.
It's a lymphoma.
Yeah, and I think this is all tuberculosis.
Now, Jeff, what about the upper abdomen? Was there anything in the kidneys?
No, I did not see anything. I can go down double. Yeah, I looked for an angiomyolipoma or something. That's just, I think that's just a little fat around the capsule. I don't think it's an AML, but that's as far down as we went.
Lymphoma or mesothelioma obstructing the thoracic duct is probably the most common cause of chylous effusions we see.
I think this is lymphoma. So that's what I wrote him back and told him that, but I don't know what they'll do. He's 90, but if it's a treatable lymphoma, I mean, it'd be easy to get a needle biopsy of that.
Right.
That's at least the cause. Now this is the best case. I'm glad we have time for it, because this is one I would have not ever come up with this diagnosis. So I'm going to just show you guys the imaging. So clearly there's what looks like something along the lymphatics here. We've got sort of this, the vessels are very conspicuous, the veins, there looks like there's stuff in the central lobular portion. The fissures are nodular. When I've seen something like this before, and it's sort of basal predominant, I've seen this in, we've seen histiocytoses, I've seen storage diseases do this, Niemann-Pick, all of this kind of stuff. And I'll show you the soft tissue windows. There's just a little bit of high attenuation material down here at the periphery, but that's about it. But I'll pull up the.
That stuff almost looks like calcium or bone there. So amyloid or alveolar chronic ophthalmos or something.
This is alveolar microlithiasis. Here's the PAP, and you can see the little clusters, calcific bodies in there. And so, and typically we've seen cases with the numerous calcified nodules just filling the lung. But, this isn't particularly hypertenuating. But so this is interesting. This is what he thinks is, if it wonders, this is just, we're seeing the lymphatics trying to clear these away. Or why are we seeing this pattern of it?
So what are the microliths composed of?
That's a good question. Let me go back to the. It doesn't look like bone. That just looks like whorls of calcium.
And these were all airways or what?
So it's alveolar microlithiasis that has a stark interstitial perilymphatic distribution. That's doesn't make any sense, but okay.
Yeah.
I mean
That's really strange.
Yeah. So the question, he was wondering, are we seeing this because it's sort of trying to be cleared by the lymphatics? But I would think the particles are way too large based on this photomicrograph here to get into the lymphatic channels. I mean, there's a vessel right there, and these things are as big as a small artery. So I can't imagine these are draining in the lymphatics unless you had smaller particles. The other thing is, are they obstructing the lymphatics? But you don't really see that. I mean, I only have this one specimen here, but
some lymphatics can be quite massive. But like, he has all these little. I mean, I don't know. That's just odd.
How old is this patient?
I don't know if he's mentioned it.
I was thinking amyloid.
I
was really amyloid on this.
I was wondering even aspiration when you have lower lobe predominant stuff in an adult.
Yeah, but to me, these aren't airway centric. The airways are nice and clean, and I don't know. I don't have a pathologist to comment on it, but they seem pretty confident in the diagnosis. It's just a very unusual imaging manifestation.
It's non-alveolar microlithiasis.
Yeah.
Lymphatic.
It classically spares the you get that black pleural line. We have complete opposite. Here's the white pleural.
It should be.
But he had one other case to send me. He hasn't sent it yet. It was really cool.
I'm with Seth on this one. I'm I'm skeptical.
You think it was just an incidental finding that?
Oh no, I don't know. I wonder if it's some sort of amyloid.
Well, I'll respond back and see if I can get some more clinical data on the patient or more information. Maybe I can get the path report. I'll ask for the path report. That may be interesting for us to read, to see like kind of where they're localizing stuff to.
Yeah.
Well, or Jeff, have your pathologist look at the picture that you showed us, because there was all that debris in those holes looked lamellated. I'm sort of made me think it was like dried up surfactant or something like that.
Yeah.
But the tissue around it those are not normal alveolar walls around it.
No, they're
Looks
thick.
to me
They're
like
too
big
thick.
interstitial
Yeah.
abnormality here.
I would love to send this to my pathologist too, see what he thinks.
All right. Well, when
Yeah.
I'll show the case, I put it in the report, so it's a pretty high resolution image, so you can zoom it in quite a bit and get a good look at it. But this
Cool.
looks like this looks like an alveolar wall here to me.
They're so laminated, it's like whorls.
Yeah.
Wow.
Yeah.
Isn't that interesting?
I think that's probably surfactant stuff that's balled up there and then calcified secondarily. So I'll
Maybe.
bet you surfactant.
And it's a secondary phenomenon.
You know what? Can I send it? Maybe I'll send it to. Yeah, you'll have it. I can send it to some pathologists too. See what they say.
Yeah.
Fascinating.
Same, yeah. Just for
There's some kind of material in here too. That almost looks like alveolar proteinosis in here. All right.
Yeah.
Well, thanks, guys.
Thank you.
Talk to you.
thanks everyone. Those are great cases.
Yeah,
Thanks.
Have a good weekend.
you as well.
I'll have some stuff for next week. See you.
Okay.